Hello, everyone, and welcome back to the Advocide Health Podcast. I am your host for today, Omar, and as you can see, my other co-host Ali is not here. He is currently traveling to Pakistan. Wishing him well. And I'll be doing a solo episode for you guys today, so it won't be too long. But I really wanted to cover some current events, and as you can see, we have our background. We have a little new mic here. So I'm also a little bit sick, so I apologize if you hear me sniffling throughout the episode. But I really wanted to get this episode to you guys. So let's dig right in. For today's episode, we'll be talking about one type of current events from CBC Health. It's a recent report from something that I wasn't really expecting to see on the news. The article was posted earlier this month on CBC Health, and it's titled Ontario Auditor General Finds Province Not Properly Overseeing Doctor Billings. Doctor Billings is a topic that honestly I haven't really heard talked about much. Not in conversations, not with people in medicine. We talk about it here and there when we talk about different specialties, but to talk about like deficiencies and things when it comes to oversight, I think that's a topic that deserves conversation, and we shouldn't shy away from it just because we feel that it's controversial or there's something that we have to hide. And I really appreciate that this article came out because it does speak to some hidden truths when it comes to Dr. Billings. So let's talk about it. Just for your own information, we'll post the article itself in the link below. But feel free to take a read for it. But just to give you a quick summary, this article is about how Ontario oversees, or actually more accurately, fails to oversee Dr. Billings under OHIB, and what that tells us about things like accountability, system design, and where our healthcare dollars are actually going. So let's set the context for you guys. So this comes from the Auditor General's annual report that is released in early December, and it includes several health-related audits that tend to happen in this report. The headline finding is that Ontario is not properly overseeing physician billings, and that includes cases where doctors have billed for more than 24 hours of work in a single day. And I know there may be a bit of a knowledge gap here for a lot of individuals. Maybe they don't know how billing works, so I encourage you guys to, search it up. There's actually a lot of information online on how certain physicians bill patients, what the structures are, what the fee payments are, and all those codes and everything. I'm gonna do a bit of digging myself, but I do have some general knowledge when it comes to that. And before anyone jumps to conclusions, the Auditor General made it very clear in this article that this is not about accusing individual doctors. It's about a system that kind of lacks the tools to flag high-risk billings in the first place. So there's a systems problem. It's not just like a couple of doctors in one practice or one hospital. So let's just make that very clear. So what's the first key finding that came from this article is that one of the most striking findings is that over the past 3 years, at least 59 doctors every year billed for more than 24 hours in a single day, with that number rising to 82 doctors just within this last year, so 2024 to 2025. And some physicians have also billed for working 365 or 366 days a year, which you're like, what? What does that mean? 366 days? That doesn't even make any sense. And others billed for seeing over 500 patients in one single day. And if you're not aware of the outflow and inflow of hospitals and clinics and kind of the patient dynamics, 500 patients is a lot for one single day. Again, specialty dependent, but still, it's an alarming number, especially for auditors, and all without being automatically flagged for an audit. That is where the real problem is. That is what this article is trying to address, that these things are not flagged. They're kind of just going under the covers. Now, the Auditor General explicitly says that there may be valid reasons for some of these patterns, but again, the problem is that if the system doesn't really flag them, the ministry doesn't even know whether they're appropriate or not. So imagine, let me make it really simple for you. Let's say that, we have kids in a classroom and they're taking a test. You've been in high school, you've been in university, you know that you usually have a proctor or someone who's invigilating an exam, right? Let's just say that invigilator just walks out and everyone is just, in the room alone taking the test. I know it's kind of a stupid example, but that is an open ground for just cheating, right? That is essentially what we're talking about here, that there's some billings that may be overbilled, and without actual oversight, it can be very common for some individuals to properly take advantage of that lack of oversight. And I think that's the real problem that auditors tend to see. And if you know about auditing, for I've worked in clinical trials, and I know that auditing is very, very important, very high level, to the T. They check like everything. So if something goes without their, oversight, then it becomes a really big problem, and it can facilitate an article on CBC Health. So that kind of makes sense as to why we're seeing this type of news. Now the real question is, like, why is this a systems problem? You may be asking that, like, it's kind of okay. Like, some people may not have a problem. Some people may be like, oh, who cares? The billing system in Ontario dates back to the 1980s. And despite decades of, technological advances that we've had when it comes to billing and, doctor efficiency, and despite the Auditor General themselves raising similar concerns nearly a decade ago, believe it or not, you can find articles on that, the system still cannot automatically identify this type of high-risk billing behavior. So imagine, this is the era of AI. This is the era of, having technology, having, all these huge advancements that have applied to every sector, not just medicine, but like law, engineering, you name it. And within these 10 years, we still haven't made that much of an advancement, or at least not have made an advancement enough to facilitate oversight for things like this, which can accumulate over time. And that means that audits are largely reactive. They rely on tips and complaints instead of actual proactive oversight. So to put it into perspective, the ministry currently has 8 staff dedicated to auditing physician buildings, the same number they had back in 2017. So between 2017 and 2025, we've had the same number of staff looking at auditing physician billings. And despite the ask for more, there hasn't been any movement in that area. So I'll leave that with you to kind of consider why that may be the case. And the money is at stake. When audits do happen, they matter, right? One post-payment audit identified, actually said in the article, nearly $1.4 million in overpayments to a single doctor who billed more than 24 hours a day, 98 times over 2 years, including one day where they billed 114 hours. So you don't need to be a mathematician or some next level prodigy or genius to understand that billing 114 hours in a single day is not nonsensical. It doesn't make any sense because we have 24 hours, right? Stating the obvious, but we have to consider those things, right? I think that's why they put these type of stats, to make you think and be like, yo, what the heck? That makes no sense. And between 2022 to 2025, audits recovered about $8.1 million. In the grand scheme of things, you may be like, medicine is where the money's at. This is not a problem. Things go here and there. But the article actually poses a proper concern, which we'll get to in a bit. But coming back to this point about the money and what's being uncovered, the Auditor General's point is quite simple here, which is that more staff and better tools, having more staff and better tools, that number could be much, much higher. And that money could be redirected towards actual patient care. So bingo, that's where we're bringing this argument, is that money that's being uncovered, it could be redirected to something that matters, which is our patients. And knowing that we have doctor shortages, knowing that we have all these problems, you can kind of question whether there is actual oversight in the system and whether we're actually doing our darn best to ensure that we improve patient care. So that's something to consider. And connecting this to the primary care crisis, so that's really where I wanted to take this. This is where it directly ties into something that many Ontarians feel every day: the lack of access to family doctors. The Auditor General points out that if waste exists in the billing system, so for example, all these things that we've talked about, and again, the goal is to review, not accuse certain doctors, then recovering that money could actually help fund more family physicians. So think about it, right? I know that the family physician crisis has many other faults. There's many other, factors in play, and probably things that would actually promote more change in a quicker amount of time. But that doesn't mean that we neglect these other gaps that we have in the system, these other barriers that, if, sought out correctly, could actually facilitate that change further. for a problem like primary care. And at the same time, the report shows that the Ontario's Healthcare Connect system is underperforming, another huge problem. Only about 11% of people without a family doctor are even registered in the system, and only 7% of eligible family doctors accept patients through it. That's a very small amount. And just like, just think about the family care crisis right now. Like, you can understand that those numbers are not acceptable. So when the government says the wait list is shrinking when it comes to the family doctor shortage, the Auditor General reminds us in this article that that list doesn't represent the true need that is in reality. And then the article goes on to talk about things about like medical schools and medical school expansion, planning those gaps, how to, uncover them. The report also raises concerns about Ontario's plan to expand medical school seats. The government based its expansion on an estimate. So this is actually quite interesting. The plan that the government had made was based on an estimate that 1.3 million Ontarians are unattached to primary care. Obviously, huge problem, big red flag. But a newer analysis suggests that the number is actually closer to 2 million. So the data that we're using to facilitate our plans and change is also kind of inaccurate. Like 1.3 million, 2 million, that's a big gap, right? So that difference actually matters, believe it or not, because according to the Auditor General, meeting that level of need would require more than 2,000 more family doctors. So they did the math and they realized that if we have 1.3 million as our statistic, if we don't factor in the extra 700k, I believe it is, then we would be missing that gap of having 2k more family physicians in need when it comes to actually filling this gap. So that's far more than the current plans account for. Again, just to add more fuel to the flame, it gets worse and worse. At the end of the day, and we're coming to a close, like I said, this is going to be a short episode. I just wanted you guys to really reflect on, all these different problems that exist in the healthcare system. We tend to talk about it a lot in conversation. Even people who are not, in healthcare, whose kids are not in healthcare, we still are deeply affected by it, especially since we pride ourselves to have a very strong healthcare system. Yet the gaps that we have are kind of being unaddressed, and we're not really, mapping things out in the right way and kind of uncovering where we could make small change. So at the end of the day, what stands out to me isn't just the numbers here, it's the pattern recognition is a huge thing here. We see a system that reacts instead of anticipates, a system that knows where the gaps are, but for example, like billing oversight, primary care attachment, workforce planning, like we mentioned all these factors and we could go on and on. So we have a system that knows where the gaps are, but it moves very, very slowly to address them. And that's really the main concern. And ultimately, patients are the ones who pay the price. It's not the stakeholders, it's not the government, it's the patients, the ones that we're serving through the system. And not just financially, but through long waits, which we've talked about again and again, fragmented care. Go back to our previous episodes, all those points we listed out, they all have this common theme of, just patients paying a price because of system level deficiencies. And obviously the most important thing, accessing a family doctor, which they're struggling to do, a basic necessity in a healthcare system. The gatekeepers of our care, they can't even access them. So to close this episode, this isn't a story about bad doctors. My intention here was not to accuse doctors or people in a specific specialty. It's just relaying that information that we got from the Auditor General, and it's really a story about system design, accountability, and political will. Oversight isn't about punishment, it's about trust. And the patients are watching, the patients are listening. And if we want a healthcare system that's equitable, that's sustainable, and what we call patient-centered, that trust has to be built in the infrastructure itself, not outside of it. And that's where we really have to work together to kind of fill these gaps and identify those areas of improvement. Thanks for listening, guys, to the Advocate Health Podcast. If this episode made you think, share it, start a conversation. Reach out to us if you want to be on the podcast itself. We're always looking for guests, and we're always happy to have that conversation. And yeah, stay curious. See you next time.